Thank you very much for the invitation to present. As we discussed just before the seminar started, I'm happy to take questions as we go along, and if you put them in the chat, then Camilla or Anthony or Nicholas will interrupt me if they wish to do so, but otherwise I'll aim to leave plenty of time for questions at the end. So I'm going to start by talking about the population scale English secure data environments that were created rapidly during the pandemic, and in particularly about the OpenSAFELY platform, which was used for the analyses I'm going to present today. That will lead me to introduce our collaborative COVID-19 vaccination effectiveness research group. I'll talk about approaches to estimating vaccine effectiveness from observational studies and tell you about our results on vaccine effectiveness and comparative effectiveness, and where we think we were successful and where we were not successful. And then I'll talk a little bit about future work and lessons learned at the end. Traditional access to routinely collected data, and I was fortunate enough to work with record linkage data from Sweden quite a few years ago now, looked like this. The researcher proposed a project, and then there would be an information governance and ethics and contracts process. Often those processes led to people giving up or the permission being declined, and so the proposed project never happened. But for approved projects, the researcher was sent a copy of the data, and they then analyzed the data on their or their organization's computer. And in principle, those analyses, the data should then be deleted once the analyses are completed. And I'm sure that you are all well aware of the problems with such processes. They're inherently insecure. I mean, we tend to use words such as pseudonymized to say, oh, well, we haven't actually got anything in the data that directly identifies the patient, like their health service ID or their national ID or their address or their name. But in fact, if you've got highly detailed electronic health record data and you know a very small amount about the person, then in general you can uniquely identify them from detailed electronic health record data. So these processes are inherently insecure. They're also inefficient because there's no incentive or framework for sharing code or code lists, meaning that, for example, if somebody defines a particular phenotype such as diabetes in the data that they were sent, there's no particular reason that anyone else would know that how they did it or that they did it. And this is also inherently opaque. So analyses done like this are not open, not reproducible. There's no way to check that results were not dredged from thousands of results that were done, thousands of analyses that were done but not reported. So during 22, the UK National Health Service concluded that it will no longer permit sharing or dispersal of unconsented, routinely collected data. So some cohort studies, notably UK Biobank, secured informed consent for data sharing from participants when participants were recruited to their study, but that's not generally the case for people who are simply for whom data are assembled as part of routine care in a health system. So the Goldacre review was published, that was by Ben Goldacre, that was published in April 22, and then the Data Saves Lives white paper was published in June 22. And the conclusion was that secure data environments will be the default way to access NHS health and social care data for research and more generally for analyses. So the National Health Service announced that secure data environments must be adopted by organisations hosting NHS health and social care data for research and analysis. These environments have features that improve data privacy and security, and help build public trust. So in this, the NHS is choosing to call these things secure data environments. They were previously called trusted research environments, or TREs, and I think this shift of name from TRE to SDE reflects that it isn't just that these are proposed to be used for research, it's that they're proposed to be used for, in general, for analytics based on routinely collected NHS data. And the process is that an accredited researcher proposes a project, there is a single advisory group from whom they request approval, and then if the project's approved, they are not sent data. Instead of that, the data is accessed via a secure remote portal. The researcher can't copy or download the data. They can conduct analyses, but outputs can only be exported from the environment after they've been checked by an independent researcher. And at the end of the project, the data remain in the secure data environment, but the access to the data is removed. Now, these things did exist in the UK before the pandemic. The Sale Data Bank holds very detailed data for Wales. Public Health Scotland had a secure data environment. The Sale Data Bank is held by an organisation called UK SERP, who provide secure data environments more generally. And the UK Office for National Statistics has its own secure data environment, providing access to highly confidential data such as health data and employment data. But until the pandemic, there was no English secure data environment and no way to access linked whole population English NHS data. And that changed rapidly during the pandemic. So NHS England created its own whole population secure data environment. This combined, as you can see here, COVID-19 data, including laboratory testing data and vaccination data, and then data held by NHS England, including hospital episode statistics, or HERS, death registry data, and an extract of primary care data derived from participants, from patients who were alive at the beginning of the pandemic, and other data such as dispensing and e-prescribing and intensive care data. And a number of specialist data sets have been added to that. That enables whole population insights on the English population of 57 or so million people. And data sets are updated monthly. The analyses that I'm going to talk about today are based on the OpenSAFELY secure analytics platform, which in principle delivers research across 58 million people's health records and has got very stringent procedures to ensure patient privacy and confidentiality. This is just the front page, so you can go to opensafely.org and learn all about it. It's an open source software platform that can be built on top of any database. It's installed inside the data centers where the primary care data, so GP is general practice in the UK, general practitioners are primary care practitioners in the UK context. Now, the design of OpenSAFELY took advantage of the fact that almost all general practices, primary care practices in England, use software by one of two from one of two commercial providers, TPP and EMIS. So OpenSAFELY is installed inside the data centers for these commercial providers, TPP and EMIS, and the data therefore do not leave the provider's data centers. All code, both the platform and the user's code, has to be shared on GitHub. You can't, you run code in OpenSAFELY via GitHub, so code sharing is just part of the process. Over 150 projects from 22 organizations have been conducted so far. And the last time this slide was updated, which was a few weeks ago, there had been 86 publications and 14 preprints based on OpenSAFELY. So OpenSAFELY implements built-in processes supporting reproducibility of analyses. So code is written and tested against synthetic or dummy data. So you specify your analysis, which anyone can register in OpenSAFELY and write code and specify an analysis and run it against synthetic data. When you're happy that the code works, you sync it to GitHub, and it's then sent to the real data via the OpenSAFELY jobs server. You can then view aggregated results via a virtual private network, a VPN, and if the results are confirmed by an independent checker, not to be disclosive, not to have any chance of allowing individual patients to be identified, then those safe results can be released. I will say, firstly, that I've never run an analysis in OpenSAFELY. The analyses that I'm going to talk about have all been run by colleagues who I'm going to mention in a moment. But all of these colleagues will say that although in principle you write your code and it works and then you run it against the real data, in practice, of course, you write your code, it works against the dummy data, it then doesn't work against the real data. And there's a long process, well, not necessarily long, but there's certainly usually a process of making your code work against the real data, which has to be done by executing the code on real data. So there is a single code base and there's a single query language, EHR query language, developed by the team at the Bennett Institute at the University of Oxford, who did the technical development of OpenSAFELY. So you can extract your code from either EMIS or TPP into a common format. You then execute your analysis code, check the output separately in the TPP backend and the EMIS backend. And then in principle, you can meta-analyze or combine outputs from the two environments to get your whole population analyses. It should, however, be noted that the EMIS, OpenSAFELY EMIS, is not currently open. There's still a process of transitioning to post-COVID analyses and permissions. And all the analyses that almost all the analyses I'm going to talk about were done using OpenSAFELY TPP, which contains data on up to about 24 million people. If you go to the jobs server, jobs.opensafely.org, you can see the jobs that are currently being run against the real data, get outputs like this, and because it's all, and then all code executed against real data is stored, is logged, and therefore can be inspected subsequently, which is one of the ways in which privacy, respect for patient confidentiality is ensured and transparency is ensured. And then for any electronic health record data, a lot of the work is in developing code lists to take the codes that are used by the medical practitioners or healthcare and health services professionals and coded in the electronic health records to derive meaningful phenotypes. And OpenSAFELY builds in procedures where any code list is stored in open code lists and therefore can be transparently located and reused. OpenSAFELY was implemented extraordinarily quickly at the very earliest parts of the pandemic, and famously they published this paper in Nature. It was the paper was submitted in the middle of May 2020 and published online in Nature on the 8th of July 2020. And they were really the first people to document the most important factors associated with COVID-19 mortality in these analyses, which were done on just over 17 million people. This is a multivariable model, and I will say that these authors were given in my view, quite unnecessarily hard time by the electronic health records community. Fizz Williamson, Elizabeth Williamson, the first author, understands causal inference perfectly well and understands the so-called table 2 fallacy perfectly well. Sure, these results are based on mutually adjusted estimates from a multivariable model, But the idea that this was somehow an egregious offence against causal inference, I think, was entirely wrong. These were incredibly useful results showing that among the most important predictors, these were the relative contributions to predicting COVID-19 mortality. Just a couple more words on the secure data environments. The particular advantage of OpenSAFELY is that it's the only way to access the whole coded primary care record on nearly the whole population of England. The NHS England secure data environment relies on an extract of primary care data that was created during the pandemic. Each of the environments includes linked data on hospital admissions. OpenSAFELY includes emergency attendances. And then there are other differences in the other data sets that have been linked within the two environments, including differences between the specialist data sets that have been linked within the two environments. Now, one of the consequences of all analyses being conducted using remote desktops is that geography stopped mattering, became unimportant. And not only did geography become unimportant, but we were all working at home anyway, I guess. And so geography had become even less important from that point of view. So we were fortunate enough to get substantial funding to conduct analyses, in particular from the COVID-19 Longitudinal Health and Wellbeing National Core Study, which was one of 6 national core studies established by the UK Chief Scientist, Patrick Vallance, during 2020. And so they funded the collaborative analyses that I'm going to show you today. And these analyses were mainly done at the University of Bristol by my colleagues Elsie Horn, Tom Palmer, and Venetia Walker. At the Bennett Institute for Applied Data Science, which is in the Department of Primary Healthcare at the University of Oxford, by Will Hume in particular, and Colm Andrews, Millie Green, and Andrea Schaffer. At the London School of Hygiene and Tropical Medicine by Ed Parker, Fizz Williamson, and Ruth Keogh. And quite early, I had started talking to Miguel Hernan about the right way to do these analyses, and Miguel became very interested and attended a lot of our calls, which were at 4 p.m. on Tuesdays every week, UK time. Many of the slides here I owe to my colleagues, in particular Will Hume, also Venetia Walker, and also my colleague Rachel Denham, who isn't actually on this list here. So thank you very much to all of them. And this group, well, our first outputs took a while to appear, and I'll talk a bit more about that. But once we got going, then it was an incredibly exciting and productive time. So the first paper, led by Will Hume, was published in 2021 in the BMJ. I'm going to say a bit more about all that. This was the comparative effectiveness of AstraZeneca versus Pfizer vaccine in health and social care workers. We then looked at waning effectiveness of those two vaccines over 6 months after the second dose. And looked at when that became difficult beyond 6 months. Ed Parker led work on vaccine uptake in people with kidney disease. I'm going to start with this paper, although it was published, it was only published last year, on which was really why it's hard to estimate vaccine effectiveness and comparing methods for doing it. We looked at the comparative effectiveness of the different booster vaccine doses, more working in kidney disease, the effectiveness of mRNA vaccines as first booster doses. And I'll also mention Andrea Schaffer's paper on which was a regression discontinuity analysis at the end. So you all know, I mean, the precise history of the rollout of vaccinations varied somewhat from country to country, but you all know that it happened incredibly quickly once the vaccines were approved, and really was a triumph of the scientific endeavor involved in developing the vaccines, doing the initial evaluations in randomized trials, and then producing them and rolling them out. So in the UK, the Pfizer vaccine was approved on the 2nd of December 2020, and the first Pfizer vaccine was administered on the 8th of December. The AstraZeneca vaccine was approved on the 30th of December, and the first AstraZeneca vaccination was on the 4th of January. And the Moderna, the second mRNA vaccine, was approved on the 8th of January and first delivered on the 13th of April 2021. And here's a chart of the UK's daily vaccine doses, first doses in blue, second doses in red, and third doses from October 21 in purple. So obviously there was huge interest in using electronic health record data to examine COVID-19 vaccine effectiveness, particularly since the randomized trials they were incredibly successful, but there were really very small numbers of outcome events in those trials. I think for the AstraZeneca trial, it was something like 1 outcome in the vaccinated group and 10 severe COVID in the non-vaccinated group. So the dramatic efficacy of these vaccines led to the termination of the trials and the imperative to roll out vaccination in the context of the pandemic, and therefore left a host of questions about vaccine effectiveness not unanswerable in randomized trials. So we had really good data on vaccination status, on testing for SARS-CoV-2, on clinical history, diagnoses, medications, and visits. We had partially observed data or inferred data on asymptomatic and symptomatic infections, COVID-19 disease severity, for example, because we knew that whether patients were hospitalized or not, but we didn't have full information on how severe their disease was. We had some information on residency and household composition, occupation, and health-seeking behaviors. Importantly, we did not know about SARS-CoV-2 exposure, and information on infections that didn't lead to encounters with health services was obviously not known. And all of these factors made it hard to estimate COVID-19 vaccine effectiveness. The situation was rapidly evolving. Here are COVID infection rates during the second UK lockdown. They peaked at over 60,000 cases a day at the beginning of January 21 and declined as the effect of the lockdown happened. There were different variants over time, and people were developing immunity. And then I've already mentioned that the new vaccines and therapeutics were developed and delivered at speed and scale. So here is the rollout in the people aged over 80 in the UK and people aged 70 to 79. And you can see that we went from nobody vaccinated in the second week in December 2020 to almost all people aged over 80 having been vaccinated by February 2020 with at least 1 dose, and then by the end of April 2020, almost everybody had had their second dose. And then the rollout happened in priority order in the UK. So although the rollout was later in the 70 to 79s, the ultimate patterns were similar. In fact, one of the earliest OpenSAFELY papers that was conducted using federated analyses on the whole of the English population was published in the British Journal of General Practice rapidly during 2021 and demonstrated very rapidly that the cumulative incidence of vaccination was much higher among people of white ethnicity than among people of non-white ethnicity, as shown in the top panel here, and was also related to presence of comorbidities, and that enabled the health system to rapidly address under-vaccination of certain groups. So at the beginning, we were all interested in using appropriate methods to make causal inferences about vaccine effectiveness. And we started arguing about which trial emulation to take. And Fiz Williamson, as I'll say in a little while, ultimately was correct in that she said we should use a sequential approach. In the sequential approach, I'll say more about it in a moment. You can characterize it as recruit gradually, then randomize immediately. I, on the other hand, had worked previously with marginal structural models, which can be characterized as recruit immediately, then randomize gradually. And I said, well, that's the way we should go. A summary of all this, and this is one of Will Hume's slides, is that Fiz was right and I was wrong. So what are the difficulties in estimating treatment effects when treatments change over time, and how do these different approaches address those? So we're in a situation in which we start off at time 0. Let's say that would be, in our case, the 8th of December 2020, and nobody's yet been treated. We split time into regular intervals. They might be days or weeks or months, depending on the setting. And over time, people are treated. Well, everybody who's done Epidemiology 101 knows that there will be baseline confounding if we're using observational data. But the problem that we have to address in order to make causal inferences is that as well as baseline confounding, that's the values of the confounders at the start of our cohort, time 0 in this slide, we also have time varying confounders. The confounders will continue, the patient's characteristics that predict vaccination and predict outcomes will continue to evolve during follow-up, and the confounders that we need to address in order to control the confounding are the values of the confounders at the time at which each patient starts treatment, shown here. So the fundamental task in a situation such as we were in trying to estimate vaccine effectiveness was to control the values of time-varying confounders at the time untreated people start treatment. And just to be clear, there are no outcome events shown on this and subsequent plots. I'm just showing timelines without outcome events. So the two consequences of that are, firstly, that there is potentially informative censoring of follow-up in untreated people when they start treatment. So the same time-varying confounders that predict whether somebody gets treated, or in our case vaccinated, predict cessation of follow-up in untreated people, and so need to be accounted for. And then secondly, we've already said we need to control for time-varying confounders at the time that treatment starts. So in the sequential approach that has been implemented in the analyses I'm going to show you now, the approach was to match each vaccinated person to one person. In principle, there could be more than one, but in our case, one person who was unvaccinated on the same day that vaccination happened in the vaccinated person. We can then match on the values of time-varying confounders at the time of treatment start. That's time 0 in the CAUSALab sense of time 0, the time that treatments are assigned and follow-up starts, as well as other factors such as calendar time and area of residence. So for each, in our case, vaccinated person, we find somebody who wasn't vaccinated on that day, who matches on time-varying covariates, and we can follow them forward. And that way, we've dealt with the confounders at the time that vaccination took place. Now, that doesn't completely get rid of the problem, because untreated people can themselves start treatment during follow-up, and we've seen that in the case of vaccination, almost all unvaccinated people are in the end vaccinated. So we have a new problem if we want to estimate the per protocol effect of needing to censor follow-up when unvaccinated people are themselves vaccinated. That reintroduces informative censoring. Of course, in some circumstances, the incidence of treatment may be quite low, and we may just be able to estimate intention to treat effects and ignore subsequent treatment in initially untreated people. But you've already seen that that's not an option in studies of vaccination, in which we start off with a cohort in which nobody's vaccinated, and we end up with a cohort in which almost everybody's vaccinated. So whichever, there's no way to estimate an intention to treat effect. So what can we do about the subsequent treatment in initially untreated people? Well, we could use inverse probability weighting. We can estimate the probability of vaccination over time using pooled logistic regression, use that to derive inverse probability weights, and model the probability of censoring the untreated people when treatment starts, and upweight the follow-up in people in whom treatment doesn't start. That would be the methodologically correct way to do it. It actually wasn't what was done in the papers on vaccination during the pandemic. We simply used the paired approach, censored follow-up for each pair when the unvaccinated person was vaccinated. And in principle, we can do sensitivity analyses in which we extend follow-up by a week or two to check whether the informative censoring is important. Now, as I said, I was insistent that we should use marginal structural models. That's pretty challenging when you're fitting a model to a very large data set. These are complex models. If you have 1 row per person per day during the vaccination rollout, you end up with more than 100 million rows. You're fitting multiple models per effect estimate. You start hitting memory and disk limits, and you have long run times. And Will Hume implemented all sorts of solutions to that, including subsampling people who didn't experience events and then upweighting using inverse probability weights, reusing treatment and censoring models, stripping down model objects, and generally coding efficiently. I think there's a question.
Yes, it's Elizabeth. Actually, I'll allow her to talk if that's okay.
Sure, go ahead.
Elizabeth. I think you need to unmute.
It was a mistake. Sorry.
Okay.
I'll just take a sip of tea and carry on.
The tech works.
Cutting a long and painful story short, when we started using marginal structural models, we always got obviously spurious effects of vaccination soon after vaccination. The randomized trials had shown that the immune response took a week or two to develop, and we did not expect the vaccines to be effective during the first 2 weeks. And we agonized during the whole of 2021 in trying to find ways to get rid of that problem, and we failed. I'll say a bit more about that. I'll show you a bit more about that. Meanwhile, Miguel was involved in a group that had very rapid access to data on the rollout of the Pfizer vaccine in Israel, and implemented the paired matched approach that I showed you a few minutes ago, and beautifully showed that they could derive cumulative incidence curves in which the cumulative incidence of outcome events tracked for the two groups for the first 2 weeks and then beautifully diverged afterwards. So this had two consequences. Firstly, I started becoming convinced, much to the irritation of the rest of the group, that the sequential approach might be the better way to go. And secondly, we thought, well, surely if we implement the sequential approach, we'll be able to get rid of the spurious effectiveness that we see in the first couple of weeks. 2 years went by, during which we tried to, well, essentially we spent so long on those early analyses of vaccine effectiveness in people aged over 70 in the UK that no one was interested in the results because so many results had already been published by the time we had concluded that there was no way we could get rid of the spurious early effectiveness. That did, in the end, turn into this paper published in the Annals of Internal Medicine in May 23 or April 23, in which we describe the two approaches, the single cohort approach, in which you fit what's conventionally known. I mean, the terminology in the causal lab is still a little confusing, but what I used to think of as a marginal structural model versus the sequential approach with matching and censoring. So what we did in the end compare results from both the methods. You can see that regardless of which method we used, we still got the spurious initial effectiveness. You can also see that we didn't get identical results from the two approaches. And I'm not sure that, I mean, we speculate in the paper about why that was, but it wasn't an issue that we ever resolved. I will also note that Ruth Keogh, who was part of our group, published a paper in Statistics in Medicine also around this time, showing that in principle, the S-demand from a marginal structural model, what we call the single cohort approach, is the same as that from the sequential trial approach. So undaunted, we carried on implementing the sequential approach, and although this was published as a preprint, I think in late 22, certainly during 23, this paper was published in Epidemiology in 2024, looking at 8 million recipients of mRNA vaccines, comparing them with unboosted controls. And once again, you can see that there were, I mean, it's less clear that the early effectiveness has to be spurious for booster vaccination because the immune response for booster vaccination happens more quickly than for first vaccine. But once again, we certainly did see effectiveness very soon after vaccine, in the period immediately after vaccination. What we did, and that very few people, so yes, you've got the cumulative incidence on the left, you've got piecewise hazard ratios on the right. For infection, you can see that the curves actually crossed, and that later in follow-up, infection rates were actually higher in people who had been boosted than not been boosted. But the effectiveness against COVID-19 hospitalization and COVID-19 death remained very, very substantial. Rather few papers on vaccine effectiveness, on COVID-19 effectiveness, have looked at non-target outcomes. And the other thing that we were careful to publish in this paper was to show that there are really, I think, surprising and implausible effects against, well, non-COVID death generally. I mean, you can imagine that COVID-19 vaccination protects you against deaths, even though those deaths aren't classified as COVID. But I think it's hard to believe that efficacy against cancer-related non-COVID-19 death could possibly exceed 50% for 6 months after vaccination. On the other hand, we also analysed fracture as a negative control outcome. And although the incidence of fracture is somewhat lower in boosted than non-boosted people, all of these people, by the way, had been first vaccinated. The hazard ratios were much closer to 1. Now, I can't fully explain these results, but I will say that transparently publishing results against target outcomes and non-target outcomes and against negative control outcomes and discussing the problems is, I think, important in studies of COVID-19 vaccine effectiveness generally, but any of these outcome, any target trial emulation more generally. We were much more successful in looking at comparative effectiveness of booster vaccine of COVID-19 vaccination. This is really much more akin to a conventional cohort. Whether you should call this a sequential design is not clear. It's not very obvious because you're simply matching people who get vaccinated on the same day with one vaccine and comparing them to somebody somebody vaccinated on the same day with another vaccine. So this paper was published in 22, led by Will Hume, and didn't find substantial differences. This took advantage of a flag for health and social care workers who were prioritised for vaccination in the UK, and didn't find substantial differences up to 20 weeks after vaccination. And we used a similar approach to look at the comparative effectiveness of boosting with Pfizer versus Moderna in England, showing modestly better effectiveness of Moderna than Pfizer, particularly against COVID-19 related hospital admission, and apparently against non-COVID-19 death. This was with more than 3 million, these meta-analyses included more than 3 million people. And so you're able to do subgroup analyses that, for example, suggested that the relative benefit of Moderna over Pfizer was greater for people who had been initially vaccinated with Pfizer than for people who'd been initially vaccinated with AstraZeneca. The final analysis I'll mention is still unpublished, much to all of our frustration. And this was a regression discontinuity analysis. So essentially using the age threshold for booster vaccination in the 22 booster campaign in England as an instrument to estimate vaccine effectiveness. And this should work beautifully. Take of vaccination at the threshold for eligibility of age 50. So that's shown in plot B, and plot A just shows the cumulative incidence by age. Some people under age 50 and not classified as clinically vulnerable were vaccinated, but there was a sharp increase in the incidence of vaccination at age 50. Despite this, we were unable to demonstrate any evidence that COVID-19, the booster vaccine, had benefits at age 50 in non-clinically vulnerable people. So you can, what we expect to see if the vaccination is having an effect is that there should be a discontinuity between the effects below age 50 and above age 50. There is certainly a sharp enough discontinuity to lead us to be optimistic that we would see it if it were there, but we simply didn't see it. And although the results were imprecise, if anything, our estimate was that all-cause mortality was higher in above age 50 than below. Now, I think that's just sampling variation, but we didn't find evidence of benefit. This paper has never been published because we've submitted it a few times and it's simply not been accepted. And it was much easier to publish papers showing that COVID-19 vaccines were beneficial, even when you were pretty clearly showing spurious benefit, than it was to show a paper suggesting that the benefit at age 50 was limited in the booster campaign in 22. The final methodological point is that we won't use the one-to-one implementation, one-to-one matching to implement the sequential approach in the future. It wastes data. It's not clear how, well, in principle, you should be using inverse probability weighting to deal with the informative censoring that's caused by, that happens when untreated people, follow-up in untreated people is censored because they're treated. And the strategy to do that when you match is unclear if there's more than one untreated person for each treated person. And matching doesn't have any methodological advantage over controlling confounding by conditioning on covariates at time 0. So the general approach for the general sequential approach is to include each untreated person in the comparison with each treated person. I see that Sophia Rain is on the call, so she knows much more about having done this successfully than me. To censor untreated people when they're treated and use IP weighting to deal with the consequent informative censoring. Standard errors have to be derived then using bootstrapping because we're including untreated people in multiple treatment groups, treatment comparisons while they remain untreated. The extent to which it's feasible to implement this approach in whole population data remains unclear because because of the size of the data sets when you include untreated people in multiple treatment comparisons. To conclude, the pandemic led to unprecedented opportunities to analyse detailed, linked, population-scale electronic health record data in England. We very much hope that access for non-COVID research will become possible in the next few months. All new collaborations were helped by the decreased importance of physical location that's consequent on accessing data through VPNs. So geography really doesn't matter anymore. Observational analyses using target trial emulation are useful to estimate comparative effectiveness while addressing confounding and other design-related biases. In the context of vaccination, it's much easier to study comparative effectiveness than to compare vaccination with no vaccination. And we weren't able to avoid all biases. I think nonetheless, we can transparently display, and we should transparently display and discuss the biases when they're there, not try to hide them. And that means that for studies of vaccine effectiveness, it's important to display results for both target and non-target, including negative control outcomes. Thank you very much. Thanks again to the team, and I'm happy to take questions.